Good afternoon. Welcome to Facebook Live. This is Dr. Bill Bird. I'm the Chief Medical Officer at CGH Medical Center. As always, thanks for joining me and taking some time out of your day to hear what's going on here at CGH. Two things we're going to do today. First one, we're going to have a conversation with Dr. Bryan Kemker, who's our otolaryngologist, our ENT doctor at CGH, and ask some questions of him regarding the work that he does. And then when we get done with that, I have some updates regarding COVID, both mainly vaccine-related type of stuff that I think you'll be interested in hearing about. But before we get to COVID, as I said, I'd like to bring in Dr. Kemker. Hi, Dr. Kemker.
Hi, how's everybody?
Welcome, and yeah, glad you could join us today. I think this is going to be a good informational thing for folks to hear a little bit more about. The fancy term is otolaryngology, but I'm going to abbreviate it, if that's okay with you, and just say ENT today as we go through.
Perfect.
Yeah, okay, all right. So, we're going to talk ENT. And before I get into the specifics, and always, folks, as we're going through this conversation, if you have questions that come to your mind that you want to have answered, please feel free to throw out a live chat, and we will try our best to see if we can answer it for you. Okay, first question, a couple questions more on personal notes than on clinical notes, Bryan. What made you interested in attending medical school? And then the follow-up to that is, what made you decide to go into ENT as a specialty choice?
Well, I come from a sort of a science background family. My uncle was a surgeon, actually started a hospital in a small town in Indiana, in Jasper, Indiana. And
in Jasper, you say?
Yes.
Okay. Yeah.
Several of his kids were physicians. My mother was a nurse. My dad was an audiologist. And so
okay.
I didn't know what I wanted to do. They said, just apply yourself, study the sciences, and actually, so I wasn't the typical person who said from the day I was born, I'm going to be a physician. Right. Opportunities and doors just opened up the more I worked, actually.
Yeah.
And then as far as becoming an otolaryngologist, my dad was an audiologist, so I was connected with that field, knew a lot of the otolaryngologists at Vanderbilt originally, because that's where my dad was. And then we ended up down at University of Florida. He was the chief audiologist, and so I knew all the ENTs and the residents, and so I was very interested in that field, knew the most about it, so that I felt that was my strength, and so that's why I pursued otolaryngology.
Okay, all right. Well, that flows pretty well. What would you say your favorite part or parts of being an otolaryngologist is?
Well, for the most part, general ENT is trying to improve people's life or quality of life. And so, if you're able to accomplish that, that's very fulfilling. Something as simple as if somebody has a wax plug in their ear and they come in and they say, I can't hear anything, and you're able to get it out, and all of a sudden they can hear and they're happy, or putting tubes in, and now the kids went from not hearing and not talking to, you can't get them to stop talking. And the parents are very happy. That's what it's all about.
Yeah, good stuff. Okay, I'm going to segue now into the clinical question stuff, and I know you're gonna rock these questions. So, like I said, if viewers have any questions, please feel to send them to us. What age do you start thinking about putting tympanostomy tubes in children's ears?
So if you look at that, it depends on the problem. Certainly, if they're very young, they're not going to have a history of chronic ear infections. But you really don't want fluid to be in the middle ear space for more than about 3 months. It doesn't matter if they're young kids or adults, because the middle ear and the ossicles are not supposed to be underwater, so to speak. You can start getting problems of, it solidifies or affects their function long term. And so if they do have fluid in their middle ear, I can put them in anytime that's discovered and needed. But if you're looking at it in terms of ear infections, that's a whole different ball game, actually.
Yeah. What's the youngest kiddo you've put tubes in their ears in?
Probably around 2 months.
Wow. Okay. That's a little bitty thing to be putting in there.
Sure, but you're thinking in terms of normal people. There's other issues. Different craniofacial disorders and Down syndrome and other reasons why people would have issues earlier. That would require intervention sooner.
Yeah. Are there any set criteria for like kids who we think of like have ear infections? Any set criteria in terms of the number of infections that a kid needs to have, or is it just kind of clinical, how they're hearing and speaking and those type of things?
Well, all of that plays into the decision. If you just look at the guidelines, the guidelines will tell you, if they have 5 infections in a year, or if they have 3 in multiple years, then you should consider placing tubes. But then, as I said, you get into other factors such as speech. So, if they're having problems with speech early on, then tubes. If they're having febrile seizures and it's because they're having infections or fluid in their ears, then tubes would be helpful. Sometimes, I like to look at tubes also as a good surveillance mechanism, because if you're not real clear as to the chronicity of the problem, if you put tubes in, then if somebody has an ear infection, because with the tube you're going to see pus coming out of their ear. The other advantage of the tube in those instances is you can use ear drops, which for the majority of kids or people actually will help to clear the infection without taking an oral antibiotic, so they're not constantly on antibiotics.
Yeah, that's good. Here's okay, with COVID being a risk, what kind of precautions do you take while checking a patient, since the patient can't wear a mask during the exam?
Well, certainly I'm wearing a mask, and wash our foam in, foam out. But you're right. I mean, that's an issue, because I have to be able to look in their nose and in their mouth and in their ears. So there is that close association. I've been lucky so far. I haven't had any issues, and now that I'm vaccinated, so that's helpful too.
Yeah, good. So let's talk about tonsils and adenoids. That's that's been a big deal since I remember being a kid. So what are the typical indications that you're going to take out a kid's adenoids and or tonsils? And I'm just curious if that has changed over the course of your career.
Yes, it has changed. And what's nice about all the protocols is that there's always an out clause in the bottom of it based on clinical judgment. So they do have an out in case there are extenuating circumstances. In terms of adenoids, to put that with tubes or make that conjunction, kids that have one set of tubes and the tubes fall out and they continue to have problems with ear infections and require a second or third set, it's suggested to take their adenoids out at the same time, and that's irregardless of size. The teaching used to be that by doing that, you're changing the flora of the adenoid pad itself, because the thought is that the adenoid pad holds bacteria that then can seed the ear for middle ear infections in these kids. So that's, one reason to take the adenoids out. As far as tonsils are concerned, you're right, that has evolved over time. Again, if you have 5 episodes, well, I think it's 7 episodes, they say in 1 year, 5 episodes in consecutive years, 3 episodes in multiple years, then that would be one indication for taking tonsils out. But what has also evolved is this whole concept of sleep disordered breathing, which would be the children's version of obstructive sleep apnea. And so that is the treatment for kids who have problems with desaturation or struggling to breathe or loud snoring, is to take their tonsils and adenoids out. But there are other reasons why people can get their tonsils out, in particular children, or even teenagers. If they have what they call a peritonsillar abscess, which is an abscess or infection that gets outside of the tonsil and develops as a pus collection. So not only does that have to be drained, but then they run the risk of having it reoccur, right? And so if the person has had problems with their tonsils and they get a peritonsillar abscess, certainly I would be willing to take their tonsils out based on that kind of history. Some people don't have any trouble and develop a peritonsillar abscess, and then, typically what I say is, well, just let's see what happens.
Yeah.
If it comes back again, then then the writing's on the wall, because once you get the second one, then they start recurring logarithmically, because that indicates that there's a hole in the capsule that is allowing the bacteria to go through and redevelop into the abscess. And so that just continues to happen until you actually get the tonsils out.
Yeah. Thanks, Ryan. Good to hear. Went to CGH 2 months ago, couldn't hear one ear, so the staff cleaned them both out real good. I started hearing again. Well, I had tubes in my ears when I was younger, so I have ear problems every once in a while, but yeah. Oh, good. Thank you. I appreciate that feedback, Brian. So, Brian, I'm just curious about something else too. It seems like around when I started medical school or so, there were a couple of new vaccines that came out, the Haemophilus influenza and the pneumococcal one for kids. For some reason, it seems like around that time, those came out. Correct me if I'm wrong on that. And I'm just wondering, have you noticed in your career as a result of some of that vaccination that the number of kids who end up needing to have tubes or have a lot of ear infections has gone down?
So history would show that was the case, because the vaccines worked against those particular pathogens. But like everything in life, in nature, you created a void, and so what happens is other bacteria fill the void, or you start getting alternate strains that don't react to the vaccine. And so over time, it's shown that the numbers of ear infections have returned to what the pre-vaccinated levels were. So initially that was true, but it didn't bear out over time.
Okay. All right. Nosebleeds. Epistaxis is the fancy medical word for that. Any suggestions for folks who tend to have problems with nosebleeds?
So, for most of these things, you almost have to divide. Kids are not small adults, so the problem that kids have versus what adults have.
Okay.
So in the children realm, certainly trauma can be anything from, picking the nose to blowing the nose to rubbing the nose to getting hit in the nose. They will have a prominent blood vessel in the anterior septum, the thing that divides the nose in half. And so once that bleeds, usually it's a continuous process, right? It seems to keep going. The whole idea is you want to try to get that to heal. So reduce whatever manipulation of the nose you have. And even people with bad allergies that blow their nose a lot can have issues. And so I tell them to do two things. One is they can use Afrin nasal spray, which is a vasoconstrictor, to help slow down the bleeding, and then you apply pressure on the soft parts of the nose, not the bony parts. You don't have to put your head back. You don't have to put your head forward. Just sit normally and apply pressure. And for most people, that will stop the bleeding. You know, if you with adults, if you start adding in Coumadin and Plavix and all your blood thinners, you know, that's a whole different issue.
Sure.
For kids, they usually don't even want you to look at them, much less do anything to them in the clinic.
Right.
So if I look in their nose and they have a blood vessel that looks like it is the culprit, usually the best thing to do if it's a continuous problem is to actually go into the OR and to cauterize it with electrocautery. This works very well. It's from what parents have told me, it's not painful for the child afterwards, and it does have a very good success rate. For adults, you know, you can baby them a little bit more in terms of, you know, try Neosporin ointment to help keep it moist, keep it from cracking and drying, trying to help it to heal. If it continues to be a problem, and you come into the office and I can see where it was bleeding from, then I can cauterize it with silver nitrate. Not quite as good as electrocautery, but certainly works in many occasions for adults. I typically don't do that in kids because it does burn, and they don't like that very much.
Right.
Don't tolerate that. If it looks like it is an arterial bleed, well, then we have to do that in the OR. So that, I guess that's the difference between adults and kids.
Right. That makes sense. So for folks, this is a common problem that I saw in primary care. You know, you have a person who's beginning to have some hearing issues. When is it, from your perspective, when is it time for them to begin to explore getting hearing aids?
So the way I usually phrase it to people, because, you know, I've seen all different kinds of hearing losses, and there's different kinds of hearing losses, different reasons why people have hearing losses, whether it's noise trauma or genetic, you know, because of age, or, you know, they had infections or something as a child, which caused that. Basically, that's a quality of life question. So when the patient, and usually it's more so their friends and family, think that they need hearing aids, that's the best motivation. If I tell somebody they need a hearing aid and they don't think they need a hearing aid, well, if they do end up getting it, they're just going to throw it in the drawer, and then that hasn't helped anybody. So there has to be some motivation. And so if they feel like they're if they feel like they're saying what a lot, or people are complaining that they, you know, the TV's too loud or the radio's too loud, or they have to repeat themselves all the time, you know, that's the time to certainly consider it. And I think those people around you are going to be the ones that are going to motivate you not only to do it, but to wear them.
Yeah.
So yeah.
Yeah, you know, that my perspective on that is that, and I think I've read about this too, is that it's really important, as soon as it's hard for folks to agree to do it, but if they're willing to, it's really helpful, because one of the things that not hearing well does is it begins to, in some ways, isolate you socially, because you're not picking up on all the social cues going on around you. And so it's kind of almost like your world gets smaller and smaller. So having hearing aids can help do a lot to keep you in many ways from almost aging because you're able to take it all in still.
Well, thank you for bringing that up. Another way to look at that is that if people feel that when they go out into crowds or go to church or meetings or wherever, and they are not hearing well or they're missing a lot of cues from the environment, then what happens is they start staying at home, and so now you're right, they become more isolated. And there have been recent reports that as a result of that, they're saying that dementia has a tendency to become more prominent or set in earlier. The hearing loss itself isn't causing that, but it's probably more the isolation as a result of the hearing loss that's contributing to that.
Yeah. Next topic. A lot of folks who are listening have probably heard of someone saying, I have a septal deviation. So what exactly is a septal deviation, and when would someone need to do something about it?
Well, so the septum is the bone and cartilage that divides your nose in half. I mean, we can see the front part of it here, but it goes all the way to the back. And anywhere along that course, you can have, either the cartilage bows into one side or the other, or you have a bony growth, or let's say you got hit in the nose or broke your nose, and then when it healed in an irregular shape. And for the most part, everybody has some degree of a deviated septum, right? I mean, nobody's is perfectly flat like a desktop.
Okay.
The question is that affecting your ability to breathe through your nose? And so that's when you feel like you can't breathe well through your nose, that's when you should think about you should have it looked at, because there's many reasons why people can't breathe through their nose, but certainly a deviated septum contributes to that. And it can contribute to, it can be one of the things that you look at as far as snoring for adults. It can, depending on where the deviation is, it can actually obstruct some of the drainage of the sinuses. So people have, developed chronic sinusitis as a result of a septal deviation. So again, when it starts affecting your quality of life, breathing through your nose, sleeping, that kind of thing, that's when you should have it looked at.
Okay. So you mentioned chronic sinusitis, and I wanted to talk about that topic too, Bryan. So as far as chronic sinusitis goes, once again, which is just a chronic infection in one of your sinuses, when is it time to think about having you surgically do something about that?
Well, the first issue with chronic sinusitis is just because it occurs right here doesn't necessarily mean it's a sinus infection, and that becomes a big dilemma for everybody trying to make that diagnosis. But if you have documented sinus infections and you take antibiotics, it gets better, and you have all the symptoms that go along with it. Usually, and I hate to sound like a broken record, but you can keep doing antibiotics if it's working, but if you're just sick of that and want a different option, that's when you start thinking about, a surgical option. And what I will do is I'll get a CT scan, will show if you have problems with chronic sinusitis, then it will show up on the CT scan.
Okay.
So then I'll be able to point out where the problems are, and then what the corrections would be if we should go down the road for sinus surgery.
Yeah. So it's a quality of life thing as well then.
Sure. I mean, surgery should always be the last option. There are other reasons why people get stuffy, obstructed sinus infections, and that's why, looking into that with a CT scan is helpful.
Yeah. So how often, if you have surgery for chronic sinusitis, what's the recurrence rate of getting that again?
Well, it depends on what the initial cause of the chronic sinusitis is. If it was from chronic inflammation or, truly just chronic sinusitis, I've had pretty good success with opening up the drainage points for the sinus infections. If you have problems with nasal polyps, that's a whole different issue that's going to potentially chronically recur and cause problems.
Okay. Yeah. Sleep apnea, you've kind of mentioned about that with kids and tonsils and that type of stuff. What's the latest on any type of surgical options for patients who have sleep apnea, adults that have obstructive sleep apnea?
Well, as you know, we kind of went through a phase where they were pushing the surgical options, and now the pendulum swung so that we're at the other extreme where you have to be very selective in the patients that you choose for the surgical options. For obstructive sleep apnea, typically it's going to be a CPAP or BiPAP, depending on how severe it is. I hate to say it, but for most American adults, it's probably going to be weight loss is going to go a long way in correcting the problem. On occasion, there are some people that will benefit from the surgical options, and whereas I used to do it probably 2 or 3 times a month, I probably do it once or twice a year now.
Okay. Yeah. Yeah, that sounds like the pendulum has swung. Speaking of, just different stuff that you do, are there any things that, like, because I think you're pretty full service in terms of the otolaryngology that you provide to the area here. What are the things that maybe are unique to that we do here at CGH and that you do that folks probably wouldn't be able to get outside of this area?
Well, there are, if you look at the ears, there are some adults that have problems with eustachian tube dysfunction, and they have to have tubes in their ears all the time, because as soon as they fall out, then they have fluid in their ears almost immediately. And a alumni of mine at University of Chicago developed a eustachian tube balloon, which is where the problem is. And so we are offering, in addition to the T-tubes, which helps allow air to get into the middle ear, eustachian tube balloon, which then can dilate the eustachian tube so that it will function better. As far as the nose is concerned, we've done quite a bit along those lines here. One of the major advantages is we have an image guidance system, which basically can take the CT scan, digitalize it, put it into a computer so that we can calibrate the instruments. And when I'm working in the nose, stay away from areas that I shouldn't be in, right? Because sometimes especially with polyps, it's very difficult to navigate because it fills the whole space. And so that definitely has improved and made that type of surgery safer, or reduces the morbidity of that kind of surgery. We also do a hybrid procedure here with balloon sinuplasty, which is also a safer way of opening some of the sinuses, in particular the frontal sinus and the sphenoid sinus. And currently we're looking at something called Latera, which is when some people sniff, their nose completely collapses at the end because it's either very narrow or the cartilage is weak.
Okay.
And that's an implant that goes in the lateral nasal wall that will give it more rigidity so it doesn't collapse, and allows them to breathe better.
Okay.
As far as the throat is concerned, for people with vocal cord paralysis, we're doing an injectable implant, both temporary as well as can be permanent. We always start with a temporary injection to help medialize the vocal cords so that they can get better function and better voice. So that's just a few things that we're doing.
Yeah, that's really cool stuff. Thanks, Tara. That's a pretty good compliment there.
Yes, it is.
Yeah, for the folk. Yeah, so anyhow, for those of you who are listening or will listen later, yeah, I'm the CMO here, but I'm going to tell you, Bryan is a really good surgeon. So if you have the things that we're talking about, you don't need to go far to get help for them. Bryan can take care of those for you. And yeah, so anyhow, we're so glad to have him here. Bryan, one final question.
Sure.
When I was a kid, I used to go to ear, nose, and throat doc because I had tubes and all that kind of stuff. And I can remember looking at the wall, and it was always fascinating for me. He had a display of all the things he had pulled out of kids' noses. So I don't think you have that display in your office. I don't think I've seen that. But what are some of the interesting things that have been pulled out of noses in your career?
Noses or ears.
Okay, ears too. Yeah.
So one of the things that was most interesting for me, there was a teenager, and instead of having a nose ring or whatever, it was a magnetic type of earring, if you will. So you put the earring on the outside, and you put the magnet on the inside, and he had it on both sides. And when he took this off, the two magnets stuck on his septum in the middle. And that was just the dickens to try to get out. But of course, you find, besides food, probably the most common thing is going to be pieces of pillows and styrofoam, not styrofoam, but the foam filling in pillows and things like that. Probably I haven't seen it out here, but one of the things that's always a thrilling moment in the ENT clinic is when you look in a kid's ear and you pull out a live roach. That usually gets everybody in a panic state.
Oh, yeah, that's good. That's good. My claim to fame is I pulled some drywall out of a nose.
Oh my goodness.
All right. So hey, Bryan, it's been great having you, and thanks for taking the time to answer some questions, and really appreciate the work that you do here at CGH.
My pleasure. Thank you.
Yeah. Okay. So that was good. I hope you enjoyed. I sure did, talking with Dr. Kemker. I want to transition to some COVID stuff. First of all, Matt, I'm going to want you to put up the weekly Whiteside County charts that we have. So Matt's going to throw those up for us. All right. So you see on the top left there, the positivity rate. That's pretty similar, if I remember right, to where we were at last week. We're hovering in that upper 7 to 8% range, which obviously back in January, I think it was, we were like 1.5 to 2.5%. So we're definitely up still. Haven't gone where we were at last November, where we were at the 25% range. And you can see the number of cases and everything like that. And then on to the right there, you see the week ending as the top one, and then the 2 weeks ending is the bottom one. So the trend is still that we have more cases this week than we did last week, more cases in the past 2 weeks than we've had in the previous 2 weeks to that. So still a trend upward that, we're having, I've been saying that we're having a surge here in our area. And then if you'll pull up my handy dandy little trend thing there, Matt. There we go. So really what I've been talking about is we have two things kind of at play here. On the top is natural immunity, which are people that get infected. And so they develop a natural immunity as a result of that. And then you have folks who get vaccinated, which also gives them immunity. So that's the group of folks that helps us to have fewer cases. And then on the bottom part, you have variants, which are some of the newer ones that are coming out. And by the way, in Illinois, I was just reading today that CDC says that about 30% of what we're seeing are the UK variant in Illinois. But anyhow, the bottom part is variants, and then kind of our behavior and how we go about living our lives in terms of situations that we put ourselves in. So right now the arrow is, I would say it's still pointing towards variance plus behavior. But if we could get that top right one, the vaccination one ramped up more and more, that's going to help to move the arrow in the other direction. And that's, I see that as our best hope going forward. So I wanted to share that with you. Here at the hospital, we've given 4,399 first-time doses, 2,725 second-time doses too. We're giving 500 first-time doses this week and 400 second-time doses. We've been talking about it and we're here. This is the first week where we're actually struggling to get enough people to get those 500 doses given. So tomorrow's clinic, we still have 100 doses to give, to fill, and slots to fill over those 500 slots. So we actually, Matt's going to pull up, so that's what you can, if you wanted to get it here. And this is the Moderna shot that we're giving here tomorrow at that site. And then if you go on to that, it'll say vaccine available. And then right in the middle there, it says available, and it says click here to schedule. And you could click to schedule that. Yeah, there you go. It's a little bigger. You click to schedule, and you have to answer the questions, hit submit. And then once you hit submit, it'll give you options of times that you can get your vaccine, and then you just register for it. So I would encourage you, if you want to have one tomorrow, if you haven't had one yet, that you can get it done. Just get onto that website. It's live. It's ready for you to take advantage of. So, and we at the hospital here, we're glad to do it, but we don't care where you get your vaccine. Just get a vaccine. One thing I will say though is that we're doing Moderna. Pfizer is the vaccine that it's approved for 16-year-old plus, whereas Moderna is 18-year-old plus. And that is a category that we're definitely seeing an uptick as in younger folks. So I would really encourage, if you're a parent, grandparent, or a kiddo who's watching this Facebook Live broadcast, if you're 16 plus, most of the Pfizer stuff is being given out through retail pharmacies like Walmart and Walgreens. So you can go to Vaccine Finder there, and they'll have those for you, and you can kind of see if they're giving out Pfizer's vaccines, because that would be an opportunity to get that if you're under the age of 18, if you're between 16 and 18. And I really would encourage you to do so. So just keep that in mind. And the reason that is that they get the Pfizer and we get Moderna, is the Pfizer's run through like a more of a, it's not Pfizer, but the retail pharmacies are more through a federal program, and we're getting ours through a state source, and that tends to be Moderna here at the hospital. I wanted to talk a little bit about the J&J situation, and all of you are aware that they've pulled that for right now, and they're doing some looking into that. So the numbers right now are about 6 people out of the 6.8 million doses that have been given have had this central cerebral thrombosis, which is a big deal. And at least one person has passed away from that, and at least one other person is very, very sick with it. So yeah, that's not good. And I think the good thing is it tells us that that's over 1 in a million. And the government is pulling that, which tells me that our priority from a governmental standpoint is safety first. I really think so. I mean, that speaks to that. Keep in mind, though, that whenever we think about getting a vaccine, we're thinking about the risks versus the benefits. So yeah, there's a risk here. Obviously, we know that now. It's one in over 1 million or thereabouts, which isn't good. I'll counter that with that between March and July of last year, the CDC says at least 4,535 people between the ages of 25 and 44 died of COVID. So that's just that period of time. I think when we looked at, so I mean, if I get it, there's a risk with getting that vaccine. But the benefit from my perspective, there's just it's much more beneficial. And, okay, let me throw another thing out for something to think about, and that's J&J, the Moderna and Pfizer vaccines. Wow, safety profile wise, yes, a lot of people have, chills, and, they have that first 24 to 48 hours, they can have some, symptoms related, flu-like symptoms. But otherwise, they've been millions and millions of people, and millions have had those vaccines and done very well. So if you think about the risk of that versus the benefit, I don't think there's a comparison. Just as of December of 2020, this is through the first, 8 months of the pandemic, enough people had died of COVID every day that would be the equivalent of 15 Airbus 320s crashing every day. I think an Airbus 320 is a pretty big plane. So I know that many people are not passing away from getting vaccines. So I really encourage folks, if you're on the fence, I know there are things to be concerned about. I think the benefits way outweigh that. So I would just encourage you to go get your vaccine if you haven't done that yet. And if you're someone who really has already had your vaccine, to those around you, start a conversation and just try to listen, but also just kind of give some information, maybe even some of what I'm sharing here, in hopes that maybe folks will move forward. We are seeing more and more folks moving forward and getting vaccines. So there are some people that just aren't going to do it, but I think there are other people who are just kind of trying to figure it out. And for those of you who are just trying to figure it out, wow, I just feel really comfortable saying that it's to your benefit, it's to our community's benefit, it's to our world's benefit for as many of us as possible to get that vaccine. So that's what I wanted to share this week. Thanks for listening, and thanks for taking the time to kind of just listen in to both what Dr. Kemker had in terms of questions to answer, as well as this COVID-related stuff. Until next week, have a great week. We'll see you then.